At the outset, a heartfelt thanks to Dr. Talwar and Dr. Jasuja for inviting me here, and thanks to Chairperson for giving me this opportunity. Well, I'll be talking about the novel target agents in gastroesophageal cancer. So if we see the gastric cancer survival in last 20 years, though percentage-wise it has doubled from 2.5 to 5.2% in 2007 and 13, but still it remains to be dismal that only 5% patients survive 5 years. And if we talk about the cytotoxics, most of the cytotoxics in a combination of doublets or triplet give a median survival of about 12 months. Hence, there is a need of new targets. And these are all the targets which are illustrated on the screen, which are under the scanner so that some therapeutic benefit can be derived. Some of them have been approved, which I'm going to discuss. So amongst all these lists, which are under some form of, in some stage of trial, these 4 markers have been approved, which are to be tested, for which we have some therapeutic drugs to produce a meaningful clinical benefit. This would include HER2, PD-L1, NTRK, MSI, and even the latest NCCN guidelines recommend testing for all of these. So if I take one of these markers one by one and start with HER2, this was way back in 2010 when this article in Lancet was published, the TOGA trial, in which on a backbone of 5-FU cisplatin, when trastuzumab was added, it was found that it was having a significant median overall survival benefit. And on the basis of this drug was approved in HER2 positive patients. But this was way back in 2010. What is new is this Destiny Gastric 01 study, in which this new molecule, trastuzumab, also known as Enhertu, in a dose of 6.4 mg per kg 3 weekly, has been compared to a regimen of physician's choice, which would be either irinotecan or paclitaxel. And mind you, this is beyond 2 lines of regimen, so 3rd line and beyond. And patients might have even received trastuzumab in their initial settings. So what are the results? There is a very meaningful benefit in terms of PFS and OS, and this molecule might form the backbone of treatment in times to come for HER2 positive malignancies, including gastric cancer. If I talk about the overall survival data, 12.5 versus 8.4 months with a 41% benefit with the significant p-value. Another thing to be noted in this trial is that the patients who were having IHC 3+ were faring much better than those who were IHC 2+ and FISH positive. So IHC 3+ were faring better. So this is one of the most upcoming molecules in HER2 positive gastric malignancies. Whenever we talk about a new molecule, we should know about the safety profile of that drug. And if we see the safety profile of this molecule, we can see in the extreme right 2 columns, the grade 3-4 events are mostly hematological, and mainly it is the neutropenia leading on to dose reduction or dose interruption. Another very significant side effect would be ILD pneumonitis, which has been found to be around 10% in various patients, and even about 0.8 to 1% patients succumbing to it. The next thing to be noted is the anti-angiogenic approach, and these are the various anti-angiogenic agents which are in fray. However, in our terms, in terms of gastric cancer, the molecule which is approved is ramucirumab, which is a VEGFR2 blocker, and it has been approved on the basis of this Rainbow trial, in which patients were given in 2nd line either in combination of paclitaxel versus paclitaxel alone, and the median PFS improved from 2.9 to 4.4 months, translating into a benefit of 52%. Also, the OS showed a clinically significant benefit with 7.4 months with paclitaxel arm and increasing up to 9.6 months when ramucirumab was added to it. Also, this drug was tested as a monotherapy in the REGARD trial. When this was in 2nd line, it was compared to a placebo. It also showed a benefit from PFS increasing from 1.3 to 2.1, though the difference is too less, but it translated into 62% median improvement in median PFS numerically, and which was again clinically significant. So as per the NCCN guidelines, the combination of ramucirumab and paclitaxel are approved in the 2nd line treatment. And now, how can we ignore immunotherapy when we talk about any malignancy in this current era? So the treatment has been there for third line and beyond. And this was a Keynote 59 study, which was a phase 2 clinical trial. These patients had been heavily pre-treated in the first two lines, and still the patient achieved an overall response rate of 11.6 with a CR rate of about 2.3%, showing that this drug might be efficacious. Also in the Attraction 2 study, where a similar sort of setting, the nivolumab was compared to placebo in a phase 3 trial, and this data was updated recently in 2020 at a cutoff of 3 years, when the graphs still continue to be separated and a benefit of 5.6% versus 1.9% in survival. Now comes the Keynote 61 study, and here the pembrolizumab, this was also discussed by Dr. Ramaswamy. Pembrolizumab was compared with paclitaxel in second line and beyond. And again, what was seen over here was that though this trial did not meet its primary endpoint, that it was not superior when the CPS score was more than 1. But when we saw the subgroup analysis, what was noted was that as the CPS score kept on increasing, the graphs kept on getting wider apart, and it was showing a benefit in more in CPS greater than 10, and even in CPS greater than 5. This was exactly similar situation even when we saw the PFS. Now coming on to ESMO 2020, what's new? This has already been covered by Dr. Anand, so I'm not going into details. These are the details of the Checkmate 6499 study and the Attraction 4 study, which have already been discussed in detail. So maybe it is the time for the combinations. These are the select ongoing biomarker-based trials in gastric and GE junction tumors and esophageal cancers, which are in the fray and for which the results are expected in the near future. And we might have some more agents targeting these specific molecules, leading on to some clinical benefit. This would be my last slide, and this is regarding the NTRK gene fusion, which we all know is present in various different malignancies in different parts of the body with different incidences. So if I talk about the gastric cancer, it is in the range of about 1.5% and GIST 3.2%. And in a study for GIST, where in this drug was given in 4 patients, the response rate was 100%. So this molecule has also been approved in treatment of gastric cancer to those subset of patients who would harbor an NTRK gene fusion. Thank you.